Hi, good morning, everyone. Welcome to our second Project Echo session. And we'll get started in just about a moment. I know that we have some additional folks joining our waiting room. And we hope that everyone's having a great start to the morning so far. Well, welcome everyone to our second Project Echo session for addressing barriers to healthcare and cancer prevention screenings for adults with intellectual and developmental disabilities. We're so excited to be with everyone in our Zoom room today. And my name is Michelle Jansen, and I'm the Community Outreach Coordinator here at Rutgers Cancer Institute of New Jersey. As the state's only NCI designated comprehensive cancer center, our goal is to prevent cancer before it starts. And in New Jersey, cancer is the second leading cause of death. 1 in 2 men and 1 in 3 women within our state will develop cancer at some point in their lives. And we know that those with an intellectual or developmental disability experience greater health disparities that can lead to a reduced rate of preventative screening and a higher number of cancer diagnoses. Before we introduce our moderators and presenters for this session, we'd just like to share a few tidbits of information about our Project Echo series, especially if this is your first time joining us for this particular series. So we encourage everyone to have their cameras turned on if possible to really encourage the flow of dialogue as well as the exchange of information and resources throughout our session today. We would also like to remind everyone just to be sure to check that mute button on the bottom of your Zoom control bar just to make sure that you're muted and there's no background noise. But we do encourage you to unmute yourself at any time to add to the dialogue, to ask questions, and especially during our session at the end of the presentation where we're all just connecting and really sharing resources and thoughts. If you're not able to unmute, you can always add your comments, any questions throughout the session to our chat box, and we'll be actively monitoring that and responding to everyone's thoughts there. So the first part of our Project Echo session today is going to involve an evidence-based presentation that will lead us into an open conversation about best practices and developing solutions for common challenges that we may face in our practice and provision of services to those with special needs. Everyone in our room today is an expert in their own right and through their own unique skill set and experiences. Our goal is really to bring all of these combined skill sets and experiences into one place where we can discover new approaches, build a set of evidence-based practices, as well as to share resources and connections to enhance the care that we provide in our different disciplines and professions. I would like to introduce our panel of moderators for each of the Echo sessions, so you're going to become familiar with us all as we go through the next 6 weeks together. This is what we refer to as our Project Echo Hub team. And, we will be the facilitators, really get the conversation flowing. After today's session, you'll also receive a link. It's going to be a Rutgers Box link, and that will have the PowerPoint presentation as well as a one-pager with all of the different resources that we've discussed during our networking session today. So our first presenter and moderator that I would love to introduce and hand the mic over to is Laura O'Reilly Estanzilis, who is the Executive Director of the North Jersey Health Collaborative. So welcome, Laura.
Thank you very much. Well, we all know why we're here, right? We're addressing barriers to cancer screening and healthcare for individuals with intellectual and developmental disabilities. I have experience as a developmental disabilities nurse, and I have worked personally with individuals in community and residential settings in addressing preventive screenings and health and wellness for longevity. We know that people with disabilities who are aging can now expect to live late into life with their peers who don't have disabilities. But many still experience changes in health function and psychosocial status at much earlier ages. So this particular presentation, Managing Comorbid Health Implications for People with Disabilities and Their Caregivers, is really relevant to this noted fact that intellectual and developmental disability is a baseline, and individuals with disability can attain optimal health through prevention and health practice. So our guest speaker, Adeola Sonaike, I met her a long time ago at an ARC conference, and I'm just thrilled to have her here today. Dr. Adeola Sonaike is Senior Vice President of Health and Innovation at the Family Resource Network. Her responsibilities include overseeing the network's public health initiatives and population health services, Epilepsy Services, Equity, Diversion, and Inclusion Committee, and Pandemic Response Committee, directing its public policy and advocacy efforts, both nationally and within New Jersey, and ensuring sustainability through grant writing, new business development, community engagement, and the formation of strategic collaborative partnerships. She serves as a founding board of director for Epilepsy Alliance America and is the chair of the National Caregivers Conference. Dr. Sonaike is also an adjunct professor at Rowan University in Glassboro, New Jersey, in the College of Biomedical Science and Health Promotion. Dr. Sonaike received her PhD in public health epidemiology from Walden University, based in Minneapolis, Minnesota. She also received a master's degree in public health from Walden University and her bachelor's degree in biological sciences from Rutgers University, based in New Jersey, as we know. Her areas of expertise include public health, epidemiology, health policy, chronic disease prevention, intellectual and developmental disabilities, and neuroepidemiology. And it is an honor and a pleasure to have you here, Adeola. I turn it over to you.
Thank you so much, Laura, and thank you to everyone for being with us early this morning and joining this discussion that we're going to have about health and wellness in the intellectual and developmental disability population. And as was mentioned in the beginning of the session today, feel free to comment throughout the presentation. I like to have dynamic conversations during presentations. I know it's slightly different considering we are using Zoom, but this is our new virtual world. And so very happy to be here, but happy to engage in an open dialogue about how we can, as a state and as different entities, do a better job at managing the comorbidities that are experienced by people with intellectual and developmental disabilities, but also by their family caregivers. So I'd first like to just introduce you to the organization that I work for, the Family Resource Network. We are dedicated to offering individuals and their families with continuing needs the greatest opportunities, resources, and services to support a full and happy life. Many of you may be familiar with our organization by one of many of our names. We were actually founded in 1970 as the original Epilepsy Foundation of New Jersey. Over the years, we have expanded, and the great thing I love about our founding story is that we were founded here in New Jersey by families who are interested in meeting one another. And so families impacted by epilepsy, recognizing the importance of having that network of other families who have a shared experience and still exist within our community today. And that's where we started. And that's something that we continue to do to foster ongoing relationships for families who have shared experiences and can share resources and their stories, their success stories and best practices. And so the families play a significant role in our organization, which is part of why our name is the Family Resource Network, because we are a network of resources dedicated and centralized by the families that we support. Today, we're also known as Autism Family Services of New Jersey. Caregivers of New Jersey, and Epilepsy Services of New Jersey. And so many of our families will come to us through the Autism wing, seeking services such as ABA therapy. Some families will come to us through our Caregivers of New Jersey wing, seeking services such as New Jersey Support Coordination, which is a support coordination service, or receiving advocacy support. And some families will come to us through our Epilepsy Services of New Jersey wing, seeking services such as seizure first aid training and recognition, seeking access to a epileptologist, or they'll come through the main door, which is the Family Resource Network, really seeking respite care and other direct support services that are that people are eligible to receive through the Medicaid waiver. And I'll talk about those services in a little bit more detail soon. But this is really who we are as an organization, this network of different entities connected to families and really supporting their lives in different ways throughout the lifespan. And we support families from the day of that diagnosis through to aging as they transition to different life stages and have different needs. And we do this through within our own organization, but also in partnership with a strong network of providers throughout the state of New Jersey. So I just wanted to share some of our values with you. As you may hear when you're speaking with people in the healthcare sector, they'll often talk about how their work is driven by their values. And that's no different for us at the Family Resource Network. And so we do believe that an individual will participate to their fullest extent possible in their own care and be a shared decision maker. We recognize that the family and the community are both vital resources for an individual. We recommend that there's leadership and participation of people with intellectual and developmental disabilities within our organization, and that is really paramount to the success of our organization and why we've been around for 51 years. We avoid duplicating efforts and services. If somebody needs a service and we don't provide it, we will connect them directly to the organization that does provide that service rather than duplicating those efforts. As we know, state resources are limited. We do aim to address the full spectrum of an individual's needs. Oftentimes when a family will call us, we will ask, tell us about yourself, tell us about your family, tell us about the loved one that you're calling on behalf of, because that really helps us to ensure that we get that full picture and can apply a whole person approach to meeting their needs. And we also believe that all of our activities should follow standards. And these standards for us are set by the Department of Health and Human Services, and there are other relevant accrediting bodies that we abide by their standards as well. And so we really are focused on providing a whole person experience that is inclusive of the individual who has the disability, that is inclusive of their family members, where we are working together to really assist them with achieving their own personal goals. So at the Family Resource Network, we have many different teams that work on different areas of the organization. My specific team works on health and innovation. And our goal within that team is to guide the Family Resource Network so that it can be a leading provider of support, education, and resources that will improve the quality of life for individuals with disabilities, for individuals with chronic conditions, and their family caregivers. And we do this through the development and provision of trainings, care coordination, advocacy, and population health management. And this is done in a way that is culturally competent and innovative. And our ultimate goal is really to improve and increase access to care. And as we talk about these comorbidities experienced by people with disabilities, you're going to see this reoccurring theme of the continued goal to be able to increase access to care, increasing access to culturally competent and coordinated care is something that's really key, especially as we look at what the nation will look like in this post-pandemic era, whenever we get there. Oops. Sorry about that. It looks like Siri is.
No need to apologize.
Technology, right? All right, I will leave Siri alone. Okay, and so who do we serve at the Family Resource Network? Our community is primarily individuals with intellectual and developmental disabilities. However, I would be remiss to not mention that we also serve people who have physical disabilities through a program that is called EDGE, and that serves people who are blind and visually impaired. The bulk of our service area is in supporting and serving individuals with intellectual and developmental disabilities. And as you've seen from the theme of this, we support the entire family. So that includes supporting their caregivers as well. Some caregivers are local and are very involved in the care of their loved one. Some caregivers live in another state. And so we are constantly part of those communications to ensure that they are informed and aware of what is occurring with their loved one here in New Jersey. When we look at the a screenshot or a snapshot of the population that we serve, we see that there is increased early mortality within the disability community in comparison to the general population. And one of the things that Laura mentioned is that, you know, with technology, with the improvements in healthcare, the lifespan of an individual with disabilities has increased significantly, but we're not there yet. We still have a long way to go, and we still see that chronic conditions such as cancer, such as heart disease, such as diabetes, are significantly impacting people with disabilities at disproportionate amounts. We're also noticing a trend of diminished health among the primary family caregivers. And this was even more apparent in the past 18 months as a result of the pandemic, where family caregivers, many of whom have full-time jobs, were locked into their homes during lockdown to complete their job responsibilities, but also care full-time for their loved one who has a disability or chronic condition. Many family caregivers do state that in that first year of caregiving, and let's just be honest, caregiving is not something that you typically have an opportunity to prepare for or plan for. But many caregivers do express that in that first year of caregiving, they feel that diminished health. They feel an increase in stress. They're not able to go to their own wellness visits because all of their free time and all of their energy is focused on caring for their loved one. And this is really, a systematic problem that we're seeing across the nation, but that has also been further highlighted over the past 18 months due to the pandemic. People with intellectual and developmental disabilities are significantly more likely to have secondary chronic conditions. I remember when I first started working in the field, as Laura mentioned, we met at the ARC conference, and there was this understanding that certain comorbidities were just a part of the diagnosis. For example, a child with Down syndrome being overweight. There was this assumption that that was just the anatomy of Down syndrome. But that is not the case. It is a systematic issue. Obesity within the disability population is due to the lack of access to healthy options, due to the lack of access to inclusive wellness programs, due to the lack of the availability of providers who are trained to appropriately treat and prevent obesity and diabetes and high blood glucose levels in people with disabilities. A study that I conducted a few years ago among pediatrics acknowledged that children with disabilities were 2 times less likely to receive a referral or receive obesity counseling from their primary care provider when presenting at the within the healthcare system and being noted as being obese or overweight. And so, and when you ask providers, why are you not addressing the whole health of your patient? There is this sense of, there's so many things on the list that we have to get through and so much limited time that we just don't get to it. And so that's a call to action for the supporting field and the public health field and the human services field to ensure that health is a component of programs, of services, of support, recognizing that if we're not addressing it in the community setting, it's not being addressed in the medical setting. The Family Resource Network primarily serves individuals who reside at home. And so many providers that you may encounter in the disability space may operate group homes. That is not something that we do in the Family Resource Network. We meet families where they are. And so that means going into their homes, being a part of their day-to-day experience, working with them in their homes and in their local communities. And the majority of the individuals that we provide direct services for are eligible to receive these in-home and community-based supports. And I'll talk a little bit about these supports in a few minutes. And so what are the comorbidities that we see within the disability population? And I've split these up between the physical conditions and the mental health conditions. Many years ago, our primary focus was really on the physical conditions. But as we are seeing an increased prioritization of mental health in the general population, we are also applying that same prioritization to the disability population. And I'm not going to go through and read through all of these comorbidities, but these are not rare comorbidities. These conditions are very significant and very popular, unfortunately, within the disability population. And they come with their own management challenges in the general population, and then you add that onto having to manage these conditions with an individual who already has existing needs. And we have a healthcare system and a human services system that is not effectively equipped to be able to manage these, even from a prevention perspective. As I mentioned, we are an epilepsy organization. That's how we started. And epilepsy is one of the most popular comorbidities that we see in the disability population. Many people will have epilepsy as a secondary diagnosis. And the spectrum, we talk about autism being a spectrum condition, and I believe that epilepsy is also a spectrum condition, and many providers in the field follow this food of thought, recognizing that the impact of epilepsy can vary from individual to individual and can really impact their daily functioning. It can, if they have their seizures under control, that's one situation. If they don't have them under control, that's another situation. But there are, here is a list of just the different physical health conditions and mental health conditions that you may encounter when treating or serving or supporting an individual who has a disability. And I want to just spend some time looking at the mental health side of things. And we see depression is listed there, and anxiety disorders. And these two conditions that we tend to see very, very frequently, irrespective of where someone is on the spectrum of their disability. We continuously see anxiety, social isolation, depression within the communities and the individuals that we support. And, this has just been further impacted by the pandemic, and seeing that, nationwide mental health, depression, anxiety, social isolation has been problematic. And so we're seeing that occur within the disability population. And now the difference is telehealth has been booming during the pandemic, and mental health services, psychiatric and therapeutic services are available via telehealth, often covered by health insurance. But when you look at the disability population and you look at an individual that, let's say, has autism and schizophrenia, and let's say they're nonverbal, who's able to treat that individual appropriately? What providers are able to provide telehealth services effectively to support and treat that individual? And that, outpatient care for individuals who we say have a dual diagnosis, meaning they have a developmental or intellectual disability, but also they have a mental health condition. Those individuals who have the dual diagnosis are falling into the treatment gap. There are a limitation in providers who are equipped to provide care for those individuals in an outpatient setting. And if they do happen to find a provider, the likelihood of that provider accepting Medicaid, which is the primary insurance that we see within this population, are slim to none. When our support coordinators reach out to me and ask me if I'm aware of any providers that can treat one of their consumers, I often say, well, I know of a few providers, I don't know if they accept Medicaid. And some of those providers will say, we'll take the case pro bono, because they just know that it's not, they're not Medicaid providers, but their understanding of the lack of resources and expertise within this sector. And so these are things that the healthcare system, when we're looking at physical health, we haven't even been able to overcome some of the gaps in the treatment gaps experienced by people with disabilities. And now we're adding to that the same exact situation on the mental health side. And so as we address these comorbidities, it's really important that we understand that there is a lack of expertise in the field. People may say, well, this individual is at a doctor's office every month. What do you mean that their comorbidities are not being addressed? They're probably seeing a specialist for their specific diagnosis. You can have epilepsy and see an epileptologist once a month, and they're just talking about what's going on with your brain, and they're looking at your medications, your anti-seizure medications. They're not necessarily having conversations with you about diabetes or coronary heart disease, for example. They're not a cardiologist. And so it's really important that we recognize that there's a difference between seeking treatment to address your comorbidities and seeking treatment to address your intellectual or developmental disability or medication management. Those are very different types of appointments. And we cannot have this assumption that just because an individual is accessing the healthcare system on a frequent basis, that their usual use that they're a super user, as we often, or super utilizer, as we often define them. We cannot make that assumption that our super users of our healthcare system are actually having their chronic healthcare conditions being addressed during all of those visits. And that's something I really want everyone to keep in mind and take home with them from this session, that there are still significant treatment gaps, even among our super utilizers. And so I saw this conclusion in a study that I reviewed a few months ago, and they said that people with disabilities need coordinated care and services irrespective of where they live, and a much earlier age than the general population. They require tailored and inclusive initiatives to reduce the inequalities. And the thing that I think is key about this is that when we're looking at comorbidities, we're often looking at it from when we're thinking of the general population and we're looking at comorbidities, we apply that public health model and we focus on prevention. When we often are looking at comorbidities in the disability community, we are often too late, and we are looking at things from a chronic disease management and treatment perspective. And it's really important that we start to look at children and look at children who, once they receive that diagnosis, and start to have those conversations and pay attention to their health and do prevention screenings and recognize that the gaps in access to care and services don't start in adulthood, they start from the pediatric side. And so if you think, for example, let's look at obesity, and we think about healthy diet and physical activity. If the general mindset is that the majority of children are able to remain physically active because they have recreation time at school, and they have physical education, and they have school sports that they're able to participate. When you look at a child with a disability, do they have those same equal opportunities? And the answer is often no. And so we are seeing this split in the availability and access to health and wellness services that occurs at a very, very early age. And so it's very important that we apply that same public health and preventive model that we apply for the general population to the health of people with disabilities as well, especially recognizing, as Laura mentioned at the beginning of the presentation, that people with disabilities are living longer and longer as the years go on, sometimes outliving their family caregiver. And so it is important that we start to apply that same preventive health model during those early wellness screenings, ensuring that our screening tools are effective and appropriate for an individual who has a physical disability, for example. Is the BMI screening the most appropriate screening tool for a child who has Down syndrome? And so there are so many different things that we have to consider in our public health and preventive health practices that need to be tailored so that they can be inclusive from the beginning to ensure that we are preventing and decreasing the risk of those comorbidities that you saw on the prior slide. And so what does this come down to? It comes to addressing those social determinants of health. And we know that that's all about where you eat, live, sleep, work, and play. And the social determinants of health have been very popular in the public health sector for a very, very long time. But they've now become a buzzword over the past 2 years as the pandemic has shone a light on the true impact of social determinants of health on our overall health. And so when you're looking at social determinants of health, there are 2 components that you need to focus on. There are the health-related social needs, and there's population health management. And so for health-related social needs, that's really looking at the strategic integration of health equity within the community before and after a person is a patient within the healthcare system, that we're just focusing on, once again, where they eat, live, work, sleep, and play. We see these individuals and we see our consumers before they enter the healthcare system. We see them after they're discharged, so they are always a part of our community, but they're not always a patient. And so that's really what it means to address those health-related social needs. And then from population health management is really looking at those complex health and social needs of our high-risk vulnerable populations and ensuring that there's true value, engagement, and access in our approaches. And so when we're really looking at different social determinants of health, you can see that it's been broken up into different areas. These different components all play a significant role on mortality, morbidity, life expectancy, healthcare expenditures, health status, and functional limitations. And the ones that you see are circled in purple, purple for the Family Resource Network, are services that you can find within our organization. We have supports for employment. We have programs that address access to healthy options. We have programs that address social integrations. We provide support systems. We focus on community engagement. We have vocational training that we focus on. I didn't circle literacy, but we do focus on health literacy. We focus on health coverage and also provider availability, and to an extent, quality of care and linguistic and cultural competency. But the ones that I've circled are really where you can kind of see from a healthcare perspective, if someone is seeking services and supports, that you can kind of see these supports and services within our programs, even though in the human services system, they can have a different name. And we also do some housing support to an extent. So first, let's look at addressing health-related social needs. So as I mentioned, that's really looking at the individual before and after they're a patient, and looking at what their life looks like and supporting those needs. And so you will see that this includes addressing employment opportunities, ensuring that work environment are non-discriminatory, and equal pay. New Jersey is a employment first state, meaning that everyone that goes through the system in New Jersey, the education system, has an employment-related goal, an employment readiness goal. And so there are many programs and services that focus on vocational rehabilitation, that focus on, job searching and job planning and job preparation and creating inclusive work opportunities. But it's also important that those environments in which people are working in are non-discriminatory, are treating all employees equitably. And I say equitably and not equally because an employee may have additional needs that need to be met in order for them to be able to do their job effectively that may be very different from the needs that somebody else has. Education and educational entitlement is a key component to ensuring accessibility to education. It's important to ensure that individuals are meeting those standards that are set in place by the state to ensure that they are having an equitable opportunity to reach their educational goals. There's a lot that has been done in the educational sector to improve education for children who have intellectual and developmental disabilities, but there's so much more that we can do. And one of the advocacy efforts that we are starting to engage in is here in New Jersey. You're considered an adult when you turn 21 if you're in the DDD service world, meaning at the age of 21, you age out of school-based services and you become eligible for state-based services. However, what happens to an individual who graduates at 18 because they're ready to graduate? Should they be held back those additional years so that they're eligible for those services at the state, or should they have the opportunity to graduate when they're ready at 18 and you still have access to those services, such as transportation to their college courses, which would be paid for by the state if they were 21, but if they graduate at 18, they will experience some challenges with identifying travel, for example. Accessibility of affordable, nutritious food. And so, many parts of New Jersey are considered to be a food desert. And when we look at the accessibility and affordability of food, when the pandemic first occurred, many people were promoting the availability of food pantries across the state. And we, as a team, did an assessment to see how many of these food pantries are truly accessible for people with disabilities. And you may think, well, it's a food pantry, why wouldn't it be accessible? But accessibility is not always about the physical accessibility. Accessibility can also include, are there long wait lines to access this pantry? If somebody is seated in the car for hours so that they can in line to access this food pantry, and there's not a specific line that is made for individuals who have additional medical needs, will this result in them missing a treatment dose or a medication dose? Will this result in them seated in one position for an extended period of time that is not recommended based on their disability or that maybe based on their physical disability? And so, there are many different factors that we have to keep in mind when we're considering accessibility. And so what we did is we developed a list of food pantries that we considered after reviewing with our coalition to be accessible, so that when families would call and we ask that question, tell me about yourself, if the question, if food and the conversations about its nutrition or food security were to come up, we have that list of food pantries that we know that this individual will have a positive experience at attaining food for their loved ones. Housing is another area that is key when you're addressing the health-related social needs of individuals. Housing needs to be accessible, it needs to be clean, it needs to be safe. And when I say accessible, not just the physical component of it being accessible, but its location. How close is it to the day program that the individual attends? How close is it to their primary care provider or their specialty provider? These components play a significant role in determining the most appropriate place for somebody to live. Do they have neighbors? Are they able to live independently? All of these components are taken into consideration. The accessibility of community groups and social support. And so, as I mentioned, things are now available virtually because of the pandemic. However, is a virtual support appropriate for everyone? No. And do people want to be in this virtual world 24/7? Absolutely not. And so, the importance of ensuring that social support and community groups are accessible to decrease the risk of things like social isolation and depression, but also recognizing that many of these groups teach really important life skills such as that we call independent living skills that allow for an individual to navigate within their own community independently or to the best of their own capacity. And this brings me to their ability to participate in daily life. And then lastly, health literacy. As I mentioned in the very beginning, we encourage our consumers and their caregivers to be a part of this decision-making process. It's person choice first. And so we really encourage and work in partnership with our families to ensure that they are the ones making the decisions that are best for them. And we are there to provide them with the information and the guidance so they can make an informed choice. And health literacy is really key to being able to accomplish that. On the population health management side, this is where you'll start to see things such as community health workers, who are individuals who live within the community, who are a part of the community, who also are trained to understand and address and navigate some of the additional needs that an individual may experience when it comes to managing a chronic health condition. Care coordination. This includes not only coordinating care within the human services system, but also coordinating care between the different systems and services. Families often talk about having a phone book of just telephone numbers of the different funding systems and the different providers that they have to connect with. And that can be very overwhelming. And so having someone to support you in that process is really key, and ensuring from a population health perspective that the systems are talking to each other to make it much more user-friendly. Home and community-based services, as I mentioned, many of the families that we do support are eligible for these home and community-based services. Information and referral, that this is a service that we actually provide here at the Family Resource Network, and our goal is to intake families, especially families who have recently received a new diagnosis, and help them navigate the human services system, help them connect to care that they need, help them connect to other families who have a shared experience. Health education, which I spoke about briefly when we discussed health literacy, and lastly, advocacy. And from a population health perspective, advocacy is key because without advocacy, you don't have a continued awareness of the treatment gaps that I mentioned, and ways in which to solve those from a policy component or a legislative component. And so all of these different areas play a significant role in ensuring that the care that's provided for people with disabilities is value-based, it's engaging, and it's accessible. And so at the Family Resource Network, we have an array of programs and services. I've alluded to many of them throughout this presentation. And if you visit our website, which is familyresourcenetwork.org, we do have a full menu of all of our services, but I am going to touch on a few of them today. So our first set of services that I'm going to talk about briefly are our direct support services. We have a very strong direct support team that provide an array of services and supports in the home and in the community to support individuals with disabilities and their caregivers. And so these include things like our in-home and out-of-home respite care, our behavioral support, which I mentioned, are services that we provide for children who have autism, our camp, which is our summer camp that is primarily for individuals who have epilepsy, but also individuals who have other intellectual and developmental disabilities and are not able to have that summer camp experience. After school programs that we do throughout the state for children, our recreation programs for both children and adults, and assistive technology services that we also provide. And that's really with ensuring that individuals have the access that they need for any home and vehicle modifications. And that's paid for through the state. And so those are some of our direct support services. I know sometimes people say, well, the Family Resource Network, we know the name, but exactly what do you do? And so those are some of our very direct services. But in addition to that, we have care coordination and family support. And the idea behind this is really to provide a single coordinated system of information and access that enhances individual choice, once again, and supports informed decision-making. And so you're going to see this reoccurring theme when serving individuals with disabilities of respecting individual choice and autonomy, but also providing support to allow an individual and a family to make an informed choice. This is done through many different ways. At our organization specifically, we accomplish this through support coordination, which really assists individuals with determining what services and supports they would like to receive in that year through their state Medicaid waiver, which are the benefits that individuals receive. We have a very specialized information and referral program, which I've spoken about already. We also have a health insurance navigator program that is focused on assisting people with selecting a health insurance plan through the state-based exchange, or with applying for NJ family care, which includes the CHIP program. And then our employment services. And so as I mentioned in the beginning, while this presentation is dedicated to individuals with intellectual and developmental disabilities, and as you see, when you're looking at social determinants of health, employment plays a key role. We have programs such as EDGE. EDGE is specifically for individuals who are blind and visually impaired. And then NJ WINS, which is our Social Security Work Incentive Planning and Assistance Program that assists people with navigating their SSI and SSDI supports and benefits. And so as you can see, you're starting to see this theme of some of those key priority areas that I mentioned in the beginning of this presentation when it applies to social determinants of health and their impact on comorbidities and the different types of services that are available with a human services organization such as the Family Resource Network. And then we have training and health education, which really aids families, once again, with making those informed choices, but also aids with navigating the system of care and training and educating providers. And so many of our training programs are consumer focused and family focused. And then we have a whole sector of our training programs that are focused on increasing the capacity of the provider sector to support individuals with intellectual and developmental disabilities. And I'm not going to go into too much detail about all of these different trainings that we have, but I do recommend visiting disabilitywebinar.org, which is where you can access our webinar series, and also paulslaw.org, which is where you can receive training in seizure recognition and first aid. As you saw, epilepsy is one of the most popular or significant comorbidities that we see within the disability population. And so as a healthcare professional, as a healthcare provider, having that training in how to appropriately detect and respond to an individual who may be having a seizure is very key. And that's a training that we provide free of charge. All of these webinars and trainings that we provide are actually provided free of charge. And we do an array of different trainings. Most recently, we've launched the Center on Nutrition and Disability, which recognized that, once again, looking at obesity, looking at access to healthy foods, recognize the limitations in access to healthy food and nutrition education for people with disabilities, but also for the workers that are working with them on a day-to-day basis, whether it's in a group home setting, a day program setting, or through respite care, and recognizing the need for training to increase the capacity of individuals to help with making informed, healthy choices. And so our Center on Nutrition and Disability has an array of resources and supports that focus on what we like to call inclusive nutrition standards of care. And then we have advocacy and community engagement, which we have been involved with since the very beginning of the founding of our organization. And we do this through continued established and trusted relationships within the community. And so, as you saw, we have our 3 affiliates: Autism Family Services of New Jersey, Caregivers of New Jersey, and Epilepsy Services of New Jersey. And each of those affiliates has a very specific approach to community engagement. So on the caregiver side, this is accomplished through our caregiver coalitions, which exist in many counties, and are an opportunity for caregiving providers to come together and really assess and discuss the issues that are experienced by family caregivers within that specific county. New Jersey is a very diverse state, and there are very specific needs. And the caregiver coalitions are able to feed this information to the caregiver task force, which has been established by the governor's office. And so our hope is that this information from the county level reaches the state level and can make changes and inform future policies when we look at things like family care leave, when we look at things like, caring for an aging parent, when we look at things like lifespan respite, for example. And then on the autism side, community engagement is established through our Autism Community Impact Board, which is comprised, it's one community impact board for the entire state, and it's comprised of both providers and parents who have a family member, or parents or caregivers who have a family member who has autism, and they talk about and discuss the advocacy needs for individuals with autism within the system of care. They do a lot of education and community education and awareness to raise awareness of autism, and also really participate as partners with us in community-based trainings and observances such as Autism Awareness Month. And we have that same structure on the epilepsy side with a community impact board that really addresses many of the different advocacy and public health education awareness needs within the epilepsy community. And then we have our Get Fit Coalition, which is, Laura actually was one of our original members of our Get Fit Coalition many, many years ago. And a lot of the work within our Get Fit Coalition continues to look at the existing treatment gaps experienced by people with disabilities and the comorbidities that I've discussed that can be positively impacted through increasing physical activity and improving diet. The Get Fit Coalition right now is involved in an effort to create inclusive, healthy communities and are building a series of accessible community gardens throughout the southern New Jersey region, in addition to providing training opportunities for group home staff to learn how to cook healthy meals. And we also, as an organization, participate in many of the family support councils across the state as an opportunity to really sit there with families and be a part of those discussions with regards to their supports and their needs. And so I just want to talk about the big elephant in the room, COVID-19. I've mentioned it throughout our session today, but whenever I think of the impact of the pandemic on people with disabilities and the way in which we are responding and planning our recovery efforts, I think of something that the UN Secretary General stated, his comments were that inclusion of persons with disabilities in the COVID-19 response and recovery is a vital part of achieving the pledge to leave no one behind. And so as we as a state, as organizations, as providers are thinking about this post-COVID era, it's really important that what we are building, because it's not really about rebuilding what we had before, because what we had before wasn't working. What we are planning to build for the future from the very beginning has to truly be inclusive of people with disabilities in order for us to ensure that what our world looks like post-COVID is inclusive of people with disabilities and is truly leaving no one behind. As I mentioned, the language such as social determinants of health and inequities in healthcare a huge buzzwords right now, but these are words that have been very popular within the public health sector for decades. But when you have a public health emergency such as COVID-19, it's not creating these inequities, and rather it's exposing inequities that already exist. And so it's really important that when you're looking at these comorbidities that we've discussed, that you're not considering that these were created because of the pandemic, or the pandemic is just highlighting some of our blind spots and our weaknesses within the health and human services system. And so I'm going to provide just two quick examples for you to really see the true impact of COVID-19 on both physical health and mental health. And so from physical health, I'm going to talk about obesity. Pre-COVID, we already knew that children and adults with mobility limitations, intellectual or learning disabilities are at a greater risk for obesity. And when we look at annual health expenditures, which is often a metric that we're able to use to see what is costing us a lot of money as a nation, and what are true health issues and public health issues, we look at our healthcare expenditures. And we were spending approximately $44 billion annually on obesity care that's related to disability. And once again, that's because we're addressing it at the on the medical side and not on the prevention side. So we're really focusing on treating it as opposed to preventing it or screening for it early in life. And we know, especially many of you that are part of the Cancer Institute, that obesity is a underlying health condition that is connected to things like cancer. But it's also, as we've seen from COVID-19, is one of those underlying health conditions that increases the risk of hospitalization and death among individuals who are infected with COVID-19. And we look at the overall health of our nation from the past 18 months, and we see that 42%, that's a very large number, 42% of adults in the US have experienced weight gain. And so when you think about the disability community that was already at a significantly higher risk of obesity in comparison to the general population, and then you see data that says 42% of the general population have experienced weight gain, we can only start to imagine what's happening within the disability population and what the healthcare system needs to be prepared to tackle in a post-COVID era. And the data at the bottom half of this slide really just talks about the disparities in of obesity among certain population. So, and this is important because when we're addressing the health of people with disabilities, we also have to look at their intersectionalities. And so an individual with epilepsy, what is their gender identity? What is their race and ethnicity? What is their employment status? Because all these factors are connected to who they are as a person. This is what we talk about when we say address the whole person. And so if you have an individual who is Black, who has an intellectual disability, what is the likelihood of that individual being obese when they walk into your practice? And so when you look at the risk, the highest risk of obesity being among Black Americans, and when you look at the 42% of adults in the US gaining weight as a result of the pandemic, and when you look at the fact that people with disabilities at a higher risk of obesity, that already starts to paint a picture for you of what you need to start to pay attention to or keep an eye on when treating all of your patients. And then from a mental health perspective, I've touched on this throughout the session today, that mental health is a concern. Pre-COVID, it was a concern. Adults with disabilities do report experiencing mental distress 4.6 times more than those who do not have disabilities. And we know that at this point, approximately 4 in 10 adults have reported symptoms of anxiety or depressive disorder during the pandemic, which is a 4-fold increase from pre-pandemic levels. And so if you think of that initial slide that I shared with the comorbidities experienced on the mental health side for people with disabilities, keep that in mind when you're, treating patients today or who have a disability, and do those mental health screenings that are necessary to ensure that if there is any anxiety or depressive disorder, that it's being addressed effectively and appropriately. And my last thing that I just want to finish up with is just, what does the future of care for people with disabilities look like, in my opinion? It looks like a system that is coordinating the care between public health, medical care, and human services. We've seen models like that, such as the accountable care communities, and we're starting to see new models such as the social care networks, such as the Unite Us platform and Aunt Bertha. The prioritization of social determinants of health for people with disabilities that's addressing their intersectionalities. The application of value-based care within the human services system. We're seeing this already on the medical side, and I do anticipate that we'll see this in the human services side too. And lastly, a whole person approach to care for people with disabilities that uses models such as those medical home models that place an individual and their caregiver at the center of their care when it comes to shared decision-making.
Wow. Adeola, you must be an amazing teacher. This is fantastic. We are actually at time. However, there are a couple of things, if you guys could hang on for 2 more minutes, all right? I would like to point out on the screen, Cheryl Incognetti, President and Chairperson of the Board of Trustees for the North Jersey Health Collaborative. And we have Liza Gundel, who is the CEO of the Family Resource Network. Thank you for being here. Adeola, that was fantastic. We have some questions for you, and if we can get those answered before everybody's got to go back to work. Michelle, do you want to share that question? It's a compound question,
yes,
but
we did. We had a question specifically relating to nutrition education. So just talking a little bit more about where you see the gaps for nutrition education for individuals with developmental and intellectual disabilities. And then there was another question after that, but I'll kind of build upon that as we go along.
Okay, so from a nutrition perspective, I think the biggest gap is the lack of training that nutrition providers, the registered dietitians in particular, have with meeting the nutritional needs of people with disabilities. And this sometimes can include individuals who are overeating, and it can also include individuals who are undernourished. And so being able to appropriately, and applying a cultural competency lens to this conversation, right? Appropriately treat an individual and provide nutrition care in a culturally competent manner that's also accessible for them is key. And that's one of the largest gaps that we're seeing, because it is important to respect the choice of the individual and guide them gently to making those better choices. And sometimes, it's difficult for providers to know how to appropriately do that. But there are training services and supports available. As I mentioned, we do that at nutritionanddisability.org, which is our Center for Nutrition and Disability.
And there was a question about special diets, right, Michelle?
There is. I'm not sure if this will be, within Adeola's wheelhouse, though I know, we have a participant that was wondering what the recommended diet would be for epilepsy, whether it's keto, high fat, low carb.
When it comes to diets for individuals with epilepsy, I always say it's really important to have that initial conversation with your epileptologist or your neurologist. A lot of people do talk about the keto diet, and that works for certain individuals, but it's really a medically planned diet that has to be done very carefully in partnership with your medical provider.
Wow. So thank you. This has been really amazing. Sherry, do you have any closing words?
I just want to thank you all for coming, for taking the time. Adeola, thank you for your very informative presentation, and look forward to our continued sessions that build on this topic of working with intellectually and developmentally disabled individuals. Thank you.
Thank you so much, everyone.
Thank you, Adeola and Liza. Thank you, everybody, for being here. Till we meet again.
And we look forward to seeing you at next week's session at 8:30. Be well, everyone.
Bye-bye.